Okay, I've done a couple of rants about case presentation and the past history, which I'm now formalizing on a video. Um, you can't do a proper case presentation unless you have the past history succinct in your mind. And the problem with these sorts of past history, this came from a GP, is that there's just stuff all over the place. It's really difficult to read this and get in your head exactly what's going on. So what I'm going to do is show you through the magic of cut and paste how to organize these things and how I organize them. So hypothyroidism, is that a vital piece of information? Sure, but it shouldn't be right at the top. So let's put it down here somewhere. Hysterectomy is a one-off. One-offs belong right at the bottom. It's probably below her back operation actually, because assuming that it wasn't for cancer, then, and it wasn't recent, if she had a hysterectomy for cancer 20 years ago, no one cares anymore. It's all been and gone, and the cancer's not going to come back and haunt her. So you can put it down there where it's in the inactive sort of level. Hypertension. Now, just for laughs, I like abbreviations because they're quick. You don't need to have everything written out longhand. And by the same token, you can use T2DM or NIDDM, that abbreviation. And I like to put these all together because hypertension is not a disease. It's a risk factor. Diabetes is generally not a disease unless you've got an acute illness of ketoacidosis or hyperosmolar HHS. The only reason for looking at diabetes is because of its chronic effects on the vasculature. So generally, from a past history point of view, this is a list of the chronic problems. So I'm going to put it with all of the chronic things, and I'm going to put them all together because you can now see that this person has some significant vascular risk factors. Now, is there anything, what have we got in here? Actually, these things are all vascular stuff. So let's put all of the vascular stuff together. This makes no sense. I don't know why people write this as separate. No, I want to cut you. Cut. So they had a non-STEMI in May 2016. Oops, why did I do that? And then they had a stent to their LAD. You can see, or maybe you can see how this non-STEMI is as a result of these things. The diabetic retinopathy gives you an idea of how much their diabetes is a problem. CT guided facet joint thing is part of their pain and mobility. So let's paste that up there. Cataract. Just fix that spelling. So the intraocular lens is not going to come back and haunt them. So the reason that you do things around this way is because you want to know what are the things that are going to come back and haunt you. Hypothyroidism, if you forget to take your pills, will come back and haunt you. Most of these other things won't. So I hope that you can see that that's actually a much simpler way of looking at what's going on with this patient. They've got significant vascular risk factors and they've got cardiac end organ disease. We don't know how bad their heart is. They may have just pure vascular disease and have a good heart with a good ejection fraction. from that, but there's no information on that in this sort of list. They've got some hypothyroidism. They've had a lumbar disc operation. We don't know whether they get chronic back pain because it's sort of, which is the important thing really. Like they've had some back problems, sure. They've had a hysterectomy. We don't know what that's from. And they've had a cataract fixed. But at least you can now start to see that the majority of problems for this patient is that they're, I guess you'd call that a mild vasculopath. They've had a single stenting. Let's go down and have a look at the medications. That's a lot of medications for somebody who seems just like a mild vasculopath. Now, I always like to put, this is a completely random list of medications. Drives me bonkers. So I always want to put the antiplatelet things together because then I can see everything. If you put all the cardiac stuff together, now, so there's irbesartan, so we'll put that up here. And there's furosemide. Oh, I've got a bit of heart failure. So that actually tells us. Metoprolol. It's a fair dose of metoprolol. So I always like to put the preventers at the top because I can sort of look at it and go, yep, yep, yep. But we're not into the treatment yet. And metoprolol in many ways is a preventer of ischemic heart disease. It's also an antihypertensive. But when we're starting to look at the heart failure side of this person, they're on an ARB and they're on 80 milligrams of furosemide a day, which is a reasonable amount of heart failure. I noticed that they're not on Entresto yet, which is sacubitril and valsartan. You've got to have class 3 heart failure. So I think we'd go up here and say this person probably has mild to moderate heart failure as a consequence of that. So let's have a look at these other lists. So fenofibrate, goes along with the statin. Paracetamol, moxonidines, an antihypertensive. I'm glad to see that they're on some thyroxine. Now, do we put the moxonidine at the bottom or do we put it together? Maybe I'd put it together with the other antihypertensives. So metoprolol, moxonidine, and irbesartan. That's the highest dose of irbesartan. You can get moxonidine 400 mics twice a day is a big dose. So this person's got hypertension on triple therapy. So you can see I'm into severity scoring. This person's got quite bad hypertension. They're at risk of getting significant renal disease from this. I've severity scored the heart failure. They're not definitely in moderate or severe heart failure because they'd be on Entresto, sacubitril. So what else have we got here? We've got some insulin. I've got to remember what Carbos is. We've got another insulin, which is a long-acting Nova Rapid and Lantus. We put them all together. Paracetamol is always the first painkiller that people are on, so I put that at the top. I can't remember what it does, so let's just get rid of it. The ribeprazole is PRN, so we'll put that right down at the bottom. And we'll put the thyroxine at the bottom as well because it's sort of important, but it's not the most important. So, pardon me. So they're on one oral and 2 different types of insulin. So I'd put down that they've gone beyond oral hypoglycemics, and now they're on an insulin regimen. And when you look at this, paracetamol and pregabalin and tapentadol, this back pain sounds like it's, certainly moderate, if not, I mean, they're not on opiates, thank God, but I'd say they're at least moderate chronic LBP. So now you get an idea. I suspect obesity is part of this, because if they've got a crook back and they're on all these various medications, I suspect that obesity is at the base of all this. Right, so now you can see how you can put together this patient's history, and you can see that they're a significant vascular path with significant mobility problems. And depending upon how old they are, they may be significantly frail. So that you can see how elegant that is in terms of a description of the patient. You get it down from a whole heap of stuff into quite an elegant summary of a patient who's a mild to moderate vascular path and has significant mobility issues, with quite significant arthritis and chronic back pain. It tells you how mobile they're going to be. Oh, and also mild heart failure. It tells you how mobile they're going to be. It tells you what their frailty is likely to be like. It tells you how good they're going to be if they have an anaesthetic. There's a whole heap of useful things that tells us. Okay, so that's number one.